I would like to look at the topic of the importance of attitude, communication, and ethics in palliative care. Before we go into that, just let's take a vote. Is there anyone in this audience here who is never going to die? So, all of us and all of our patients will be in that boat one day. And so, in a way, it affects us all. And the questions I would acknowledge you, but never mind, please bear with me. Next slide, please, sir. So the questions I would like to look at is communication nice or necessary? Why do we need to apply an ethical framework in our clinical work? And how can we retain an attitude of empathy and respect? I believe most of our students come in with some innate empathy. Otherwise, they would not, many of them would not be choosing this field. So next slide, please. So to look at communication, I would like to share with you a true story. The clinical details are all true. Some other things I have changed for patient confidentiality. Next slide, please. Previous slide, yeah. So this was an affluent, well-educated mother of two in her 30s who was referred to our palliative care clinic with multiple path fractures that had been fixed. This is not her bone scan, but her bone scan was something like this with extensive bone metastasis. Next slide, please. Now, I grew up in the time when we didn't have communication skills training, but in 1995, I heard Dr. Robert Twycross from Oxford touch upon this topic. And one thing which he said then, use open questions. I think that is still the golden principle of communication for me. And the wonderful thing about that is you don't need very big training to be able to ask an open question and then to listen to the first statement without interruption. I can change it here. Yes, that would, yeah, thank you. So my favorite opening prompt when I see patients in cancer or palliative care, when I used to see was, tell me from the beginning how your illness started. And then just for 2 to 3 minutes, listen without interruption. And as I did that, I could get her medical story. She'd had an early breast cancer, which had been resected in a very good hospital in a distant part of India. She had completed radiotherapy and chemotherapy. She was asked to take hormonal tablets, but she'd stopped that a couple of months ago. And then she had come down to Tamil Nadu to visit relatives. And while going for a walk in the morning, she had fallen into an open well. We have many open wells in our state. And then she'd fractured some bones and they'd been fixed. And then she was sent to us for palliative care. So what should I do? Should I give her morphine? Should I give her some palliative radiotherapy? Maybe will non-steroidals be enough? She probably might benefit from bisphosphonates. Does anything else cross your mind? Okay. Now, as I listen to the story, and I generally look at the key investigations before I call the patient in, so I can look at the patient's face when I'm taking the history, something was troubling me, and in communication, we need to clarify. But to clarify this question, I asked her relative to go out. And then I asked her, see, in order to really help you, I need to understand what is happening. So can you tell me, did you accidentally fall into the well or did you deliberately jump into the well? And then she said yes, she was trying to commit suicide. So, and that must have been due to something very difficult, I said, because you have 2 children who depend on you. So then she told me the real story, that she had been told that the hormonal tablets might cause some edema of the limbs. And hormonal tablets can cause deep vein thrombosis, we know that. But she actually didn't have DVT. She had lymphedema after surgery and radiation. But you know how each of us, we attend a class, we take away some point that we like and we forget other things. So she had held on to that point, and when she got edema of the arm, she thought, I'm going to become really ugly, my husband is going to leave me, and then there will be no one for the children. But if I, get rid of myself now, the children can continue with him. So that was her thinking. Okay. And so the hot spots that we were seeing on the bone scan were because of trauma. They were not because of metastasis. The bone scan was taken after she'd presented with the fractures. So here was a lady with a very curable cancer whose lifespan was likely to be normal, but a communication gap had led to a suicide attempt. And just by allowing her to say the story, listening with an open mind, providing a safe space, and by clarifying, we had understood that the real need was not morphine, but something else. So what was the real need here? I was worried that she might attempt suicide again. I needed her to see the psychiatrist. Now, we need communication not only to make a diagnosis, but also for the patient to adhere or comply with treatment. And if I just gave this patient a referral to the psychiatrist, she may or may not go, and her relatives don't know this whole story. She's in a wheelchair, she can't easily come back. So then I phoned a senior psychiatrist and requested them whether they could see her the same afternoon. And I explained to her the need for that, and then called the relative in and said she also needed to see this doctor for her pain and other issues. So 6 months later, the patient came in, and she was walking in, no wheelchair, she was on her hormones, antidepressants were being tapered, big smiles. She was back at her job with the multinational. And it was really very satisfying to think that, these children and this husband still had their wife and mother. So to answer my first question, communication is not just nice, but necessary for both diagnosis and treatment. And this is a favorite quotation made by an anthropologist who studied medicine. An act of communication can be a life-saving intervention. Let me twist that quotation a little bit and say, a communication gap can be a family-destroying intervention as well. And with that, I turn to the second part of my talk on ethics. We all know the cardinal principles of medical ethics, which I have just put in slightly simpler words here. Autonomy, the right to self-determination, which includes confidentiality, informed consent. Beneficence, acting for the benefit of the patients. Non-maleficence, minimizing harm. And justice, an equal and appropriate use of limited resources. So my second slightly modified true story is again from more than 25 years back. A clerk from Karnataka who was referred to the palliative care clinic. Prior to that, he'd been coming to CMC for over a year. At presentation, he had stage 4 disease. He'd taken first-line chemotherapy for 6-8 months. The disease had progressed. He'd taken second-line chemotherapy. The disease had progressed, and now he had been referred to us. So when I told him that the disease was incurable, he started crying, and he said, I have 2 small children. My family depends on me. I came for the best possible treatment so that I would be cured and I would be there when they grow up. And now I'm going to die, and my family has lost the house. They are in debt. Why did the doctors fool me? Now, I know none of my colleagues deliberately fooled him. I know nobody's getting any financial advantage of recommending the state-of-the-art treatments, but there had been a gap between what he was told and what he had understood. So, as we know, ethics is not just a matter of organ donation or being brain dead or stem cell research. It is something that we apply every day, multiple times. And if we apply the cardinal principles of medical ethics to this case, justice, was this an equitable and appropriate use of that family's life savings to get a few months more for that patient? Was informed consent truly informed? He was expecting something else, we were doing something else. And then the bottom line of it, did the benefits of treatment outweigh the harms? So when we communicate in a palliative situation, now in cancer we are lucky because often it's fairly clear when something is incurable. In several other chronic diseases it's less clear. We need to be clear about the prognosis, that it's difficult to cure. We may reduce it for some months or a few years. We don't say, so therefore the best treatment is this, and that is what we should take. We have to give them options, that the most expensive treatment may cost this much for this long. The alternatives are this. And then there is also the alternative of just taking symptomatic treatment. And then do we ask them to decide? Now, if you and I went to buy a phone or a laptop, we wouldn't want to make that decision in the first shop that we went to, isn't it? We'd like to come back and discuss with us. And these decisions are much more important than our choices of a phone or a laptop. So after telling them the benefits and the harms, and among the harms, we also need to consider the principle of time toxicity. I have 9 months more to live. Will I spend 6 months of them going up and down hospital in another town? And then ask them to take time to discuss with their family and decide. And if they still seem to be making unrealistic decisions, it's worth checking back. Okay, you want to do this, but what are you expecting from it? Because we don't want our recommendations to destroy a family's future. So now let's have a little vote, okay? Maybe take 1 minute to think about it. Today, if you, not your patient, if you learned that you had an incurable disease with only a few months to live, what would be your top 2 priorities? So we'll take half a minute's pause to think about this important question. Okay. So maybe we've got some answers, and those answers may vary a little bit with age. So how many of you said time with family or friends? Hands up. And how many of you said the latest state-of-the-art medical treatment? Hands up. Not even one, okay. How many of you said financial goals or other important responsibilities? And how many said daily blood and electrolyte monitoring? Again, not even one. So the thing is, so the same things apply to our patients who come to us with incurable disease, but we look at them with the lens of a doctor and a diagnostician. Okay? So I think I would like to suggest that especially in incurable disease, but also in many chronic diseases, personal priorities are often more important than state-of-the-art treatment protocols. And to understand those priorities, again, we have to go back to listening. You're all familiar with the mnemonic ICE. Right? It involves active listening. Ideas, what does the patient know or think about the diagnosis and prognosis? In both the cases that I quoted, there was a mismatch there. There was a clear flaw there. Expectations, what is the patient expecting from us? And concerns, what are the major priorities or concerns?